Welcome to Reducing the Pucker Factor podcast, presented by the Blakery Content, the show to make every EMS and critical care provider feel sharper, calmer, and more prepared when the pressure is high and the patient is small. Here, we're going to dive into real conversations that matter: pediatric readiness, high stakes, decision-making, pre-hospital innovation, and the human side of caring for kids and families in their most vulnerable moments. From the scene to the sky, from the med unit to the helicopter, this is where EMS meets clarity, confidence, and community. Whether you're an EMT, paramedic, nurse, or flight clinician, our mission is simple: reduce the pucker factor. One practical insight, one expert guest, and one powerful story at a time. But before we get started, a quick reminder: the content in this podcast is for educational purpose only. Always follow your local protocols, policies, and procedures, and practice within the scope allowed by your state and your medical direction. Every system is different, every patient is unique, and your agency's guidelines always take priority. Now, take a deep breath. Let's get ready to turn that chaos into confidence. This is Reducing the Pucker Factor podcast. Let's get into it.
For the medics in the front line, let's go. For the flight teams on the lifeline, let's go. For the ones who are running faster, we're reducing the pucker factor. We're reducing the pucker factor, turning fear into confidence. From the med unit to the helicopter, bring the calm when the chaos won't stop. Yeah, we're the Blakery content crew, leading what the pros now do. Turn the fear into calm under pressure. Pucker factor, gone forever.
All right, so welcome back to Reducing the Pucker Factor, the show where we talk about the moments that make even the best trained clinicians pause, and the people who spend their entire careers making sure we don't freeze when those moments arrive. So today's guest is someone who has quietly, relentlessly, and profoundly changed how this country thinks about children in disasters. Not just how we care for them, but whether we even remember to plan for them in the first place. So Patricia Frost. And Patricia is the president and executive director of the National Pediatric Disaster Coalition. And she's one of the most respected national voices in pediatric disaster preparedness, pediatric readiness, and system-level emergency planning. And she's been a pediatric and neonatal clinician for more than 3 decades, a transport nurse, a nurse practitioner, public health nurse, a county EMS director responsible for more than 1 million people, where she built quality improvement programs and systems of care that many regions still don't even have. She's taught disaster response to frontline providers across the country, helped shape pediatric preparedness strategy, advised federal agencies, and served as adjunct faculty for the Harvard Medical School Pediatric Disaster Medicine Fellowship, as well as Texas A&M Engineering Extension Service, National Emergency Response and Rescue Training Center. But what truly sets her apart isn't the resume itself, it's the conviction. Patricia has spent her career challenging one of the most dangerous assumptions in emergency care, that kids will somehow fit into adult disaster plans. And her work makes one thing painfully clear: pediatric readiness isn't just a pediatric problem, it's a system integrity problem. And when we get it wrong, the cost isn't inconvenience, it's survival. So today we're talking about why pediatric readiness saves lives before the hospital, why roles like the PEC matter more than most agencies realize, and what rural and volunteer services are up against, and what's coming next with the 2026 Prehospital Pediatric Readiness Assessment. So this is not theory. This is not policy for policy's sake. This is what happens when that call is ugly, the resources are thin, and the patient is 5 years old. So, Patricia Frost, welcome to Reducing the Pucker Factor. Thank you so much for taking the time to sit down with me and chat about something that I know we are both very, very passionate about. So welcome.
Well, thank you, Christopher. It is a pleasure being here, and I am just overwhelmed by the introduction. Truly, thank you. Very generous.
Absolutely. Well deserved. So, all right, Patricia, let's, before we really dive into the deep stuff, we're going to start with just this quick rapid fire round. Okay. So the rules are pretty simple. one or two words or one sentence max, just kind of the first thing that comes to your mind. And once we're all done, we can circle back if you want to dive deeper into any of the answers further before we kind of move to those main topics. But so if you're ready, we'll just jump into it.
Okay.
All right. So, number one, what is the biggest myth around pediatric disaster preparedness?
That adult practitioners are not capable of doing it.
Okay.
It just lives in pediatrics.
Yeah. What is so number two? What's the biggest gap between policy and reality in pediatric preparedness?
It's operational and it's in the implementation.
Okay. So number three is finish this sentence. Pediatric readiness is really about.
Saving lives of children.
Okay. I like it. Number four, one word that best describes pediatric readiness in the U.S. right now.
Disjointed.
Yeah. And then the last one here, one thing every EMS agency should fix before the next disaster.
Have a pediatric emergency care coordinator.
All right. I like it. So, do you want to circle back on any of those or you want to just kind of keep moving forward?
Yeah, just so let's keep moving forward.
So, all those answers all kind of circle that same uncomfortable truth, right? So, when systems aren't ready for kids, children pay the price. So let's kind of get into this directly. And what is the actual survival benefit of pre-hospital pediatric readiness, and why does it matter long before a child ever reaches a hospital?
Well, I mean, we now have real data that basically shows that there is a 60 to 76% lower mortality rate when you have pediatric readiness in place. Now, that's measuring it from the emergency department perspective. But what you need to appreciate is that depending on your system, how many children EMS actually brings to the emergency department. So those statistics are represented there, and in fact um, may actually be a larger portion of that survival because when there's a critical kid in the community, people are going to call 911. I haven't seen, and the statistics may be out there, but I haven't seen if they've broken that piece out yet in terms of the survival and how much was brought out in EMS and how much was, walk in or along those lines. But I would guess that a very significant percentage of the children they're talking about with those improved survival rates really have been brought in by EMS.
Okay. Yeah, and so that's one of the things we talk about often is the uh, amount of pediatric patients that EMS agencies statistically see, and the numbers that I saw is that nationally it's around 6 to 13% of the agency volume, and for
Right.
some of the agencies, the more rural agencies, they're less than 1%. And we'll get into rural a little bit later here, but so they see such a small amount of pediatric patients, but when they do, they can truly have such an impact on those patients.
Well, I certainly learned that as part of my experience in working with Contra Costa County in their emergency medical services after decades of working in an academic center in pediatrics. I came on board as a pre-hospital care coordinator and was in charge of not only the education but also the quality improvement for helping the other agencies coordinate that, within our county system. And it was through those eyes that I learned how important children were in that scenario. W- Um, and I came to it in an interesting way. I don't know if your audience knows, but every state has an EMS for Children's program. And in that EMS for Children's program that has been around for more than 40 years now,
Right.
uh, w- that program has been the national initiative to improve emergency care for children for decades. And yet, I find myself in various groups with EMS and also healthcare, public health, emergency department, um, and even sometimes pediatric groups, and they don't know about the program.
Right.
So, the reason I'm giving you that background is that when I first came to my county, one of the first things that I did was I did a walkabout and basically touch base with every emergency department, every fire agency, every ambulance agency to assess where our county was in terms of and what their needs were in terms of being comfortable with caring for children
Uh-huh.
in that situation. And also for me to learn what assets they had, what education they had, how was the education working, what protocols we had. And just so kind of doing a refresh of how the county had implemented the EMS for Children's program in 1990. And basically came across every single stakeholder group being absolutely terrified about
Yeah.
the potential of having a mass casualty for children, having a disaster involving children, but also feeling really insecure about what to do in that situation. And so through the EMS for Children's program at the local level, at the county level, we really began an effort to improve the care. And that was before the Readiness system actually got implemented. But it, it is in that assessment that you get a baseline and then you can begin the process of bringing people together for improvement because the improvement has to start with them. It's not something you kind of, okay, you give them some things or you tell them what to do and I have a magic wand and it happens.
Right.
It doesn't happen that way. You have to have people who are actually invested in the effort.
Yeah, absolutely, and that'll get us to the PEC portion and that care coordinator here shortly, but, I that's one of the big things, like, kinda stepping back, that's one of the big things that I stress in my lecture is, like, how do we actually start this process? And it's by taking stock of what we already have, right? Do
Mhm.
we have pediatric protocols? Do we have pediatric resources or reference cards or, any of that sort? And just evaluating that where we're at now so that we can build from there moving forward. And I highly encourage people, once you have that information, to just take small little wins, pick one or two achievable
Mhm.
tasks and achieve those. And then continue to just build on that and build on that. And that's how you show that it's sustainable and possible.
Well, Christopher, I completely agree, and I love the way you frame that. Um, what's so interesting to me about the EMS community is that, the EMS community has strong skills for sizing up a situation in the
Uh-huh.
field and getting the situation awareness before they get into the call. I mean, there's it's part of the culture. It's part of the culture in order to kind of okay, what am I getting into? You don't walk into a situation blind, but in in this situation when we're trying to improve the care of children, we really need to lean forward in the same way and size up the situation. But the thing we're sizing up is what are our programs, processes, education, and and then what is the care and the numbers of patients and what types of patients. And so all of that informs your strategy in terms of how you're going to approach and intervene in the scene. And so, if we
Yeah.
can make it more part of our culture that we already have in place in EMS, I think that would be a terrific plus because you have the I mean, people have the foundational skills to do that. You shouldn't be intimidated that you can't wrap your arms around this.
Yeah, and so there's a couple things there. One of the things that I say in my lecture is to reduce that pucker factor. It's all about figuring out those stressors, right? And stress is predictable, and when something is predictable, it's trainable, right? So one of the things I
Mhm,
say is, so the rest of this lecture is really about uh managing the predictable things and taking assessment and figuring out, okay, these are the calls that we're most often see. This is the age group we're most often see. This is why they're going to be, that
mhm,
age group is most likely going to be calling. And then we end up and turn that into the training and we start to
yeah,
prepare for those. And then that allows us to build on that into the QA/QI process and track all that and just loop it all back in so that then you start to see, okay, we're having some errors here. We're not doing this consistently. So that becomes your next training. And then you start to build on that and just continue to just build and build from that into that state of readiness. And I can't tell you how many EMS providers that do walk into these situations all the time, do scene size up and all that stuff. And every time they hear pediatrics, that they get that pucker factor, they get that
mhm.
stress response, they get the increased heart rate, because they're just not comfortable and they're not confident. And I say this all the time. I've been accused of being a pediatric expert way too many times, and I say I'm not an expert by any means. I've just been exposed to it a little bit more than you have. I've had a
Yeah,
little bit more exposure, and that's all it takes is just getting some exposure and building that confidence and comfort level to be able to manage those situations. And your heart rate, I always say, like, your heart rate might still go up, but your brain has a plan at that point because you've started to
yeah,
prepare for it. You're a little bit more comfortable, and then you can respond and manage that situation appropriately.
yeah, I absolutely agree. Yeah, I'm kind of dating myself, but I was, involved in the, Stanford paramedic program back in the day when I was at, Stanford and, in their children's hospital. Eh, you know, we just have a very short period of time in which to teach, um, what they needed to know, a
Yeah.
day or 2 as far as that's concerned, and that amount of time really is not sufficient for, people to actually do the work, and then when you finish your training, then you go into, you know, a phase where you're doing ride-alongs, and that can be very helpful, but, again, the frequency or lack of frequency, I should say, in terms of actually, being with a kid is a real challenge. Um,
Yeah.
if in a perfect world, I would love to be able to see, these programs uh, really have a chance to interface with normal kids to begin with, of different developmental ages, so
Yep.
that you know what is normal. You know what
Yeah.
is
So
normal.
So I recently talked to, so it's interesting because Dr. Antevi, when I interviewed him, had
Mhm,
essentially the exact same statement, right? Is that
yeah,
the paramedic program is this year and a half course, and pediatrics is this small little window in the middle. And he was shocked to hear. So I actually worked with one of the paramedic programs in the region, and what they did was they spread pediatrics out through the entire curriculum. So if they were talking about respiratory, they included pediatrics in the respiratory. And they were like, all right, here's the treatment when you're talking about asthma. Here's what an asthmatic looks like. Here's how we treat it. And then at the end, it's like, and here's how pediatrics is a little bit different. All that other stuff is the same. here's where pediatrics is a little different and you need to, but they spread it out through the entire course. And then I was working at the regional pediatric center at this time. So we partnered together and these paramedic students would come through and do 60 hours of clinicals at our pediatric center
Oh, wow. That's
in
awesome.
throughout the entire year, and not just in a small window, they did it throughout the entire curriculum, and, I got them set up where they did time in the ED with a nurse, they did time in the ED with a PEM attending, and then they would go to our transitional care unit, like our step down unit with a pediatric respiratory therapist, and that's where they saw the trach vents and, did a lot of suctioning and bagging, and then they also went to, PICU, and then they also went to NICU, where
Mhm.
they went to both, feeders and growers. We would send
Mhm.
them up there and have them hold babies and feed babies, and, they also they went to, like, the high level NICU where they got to see the 24 weekers that was hands-off care,
Mhm.
and then they also went to the burn center, which was adult and pediatrics
Mhm.
both, but we really and I would do their orientation, and I really stressed to them, like, "Listen, we don't want you to come in here and think I have to do X amount of skills. I have to do this many IVs or this many suctioning or whatever." I said, what we want you to do is come in here and get exposure. We want you to see and differentiate between sick and not sick and see what kids look like as they're growing. And a lot of these are 20-year-olds that have never held a baby or
Oh,
so
yeah.
so we really tried to just get them exposure so that they could start to differentiate between that sick and not sick, and they did it through the entire year. And I'm hoping that that takes off across the country and more programs are doing
What a
that.
great
Yeah, so, like, I've always bought into that mindset that, uh kids are not just small adults, and to some degree, like, I still buy into that, but on the other part of it, as I started teaching more and more courses, like, the tactical stuff of, like, stop the bleed and, like, wilderness stuff and some of that things where I'm like, "Wait a minute, all the treatments are exactly the same," right? So, in some cases, they are, but there is still a significant right, there's psychological differences, there's anatomical differences, there's growth and development, but 85% of it is the same,
w
and then
it
get then deal with those nuances that are different, right? Does that make sense? How do you feel
Oh,
about that?
well, I think that's an extraordinary program that you just described. I
Yeah,
wish it was available for everyone because we'd be in
right.
a whole different place,
Yeah,
than what we are right now. But, in the training that I was giving, that was more limited and not as robust as what you're describing. Basically, the emphasis of was basically the early assessment of the pre-arrest state. If you have to focus on one big, huge priority with kids, it is being able to recognize and assess for the pre-arrest state
yes.
because by the time that is the most linchpin. So when um, when you're using that pediatric triangle and you're
Mhm.
walking on scene and you're looking across the room, you have to make that decision.
Yep.
Okay, is this child in a pre arrest state? And you're going to need to incorporate the help of the family in order to
Yes.
get some suitable information um, in order to sometimes make that assessment. That's especially true with children with complex medical needs
Yeah,
because they look completely different and it may be absolutely normal for them.
right. Yeah, absolutely. And so I one of the things I teach very heavily is like there's this old school thought that pediatric patients compensate and compensate and compensate till they don't, and they look great. And then all of a sudden, there's this imaginary cliff that they fall off of, and once they fall off of it, it's hard to get them back, right? And I buy into that. But what I also teach is that the problem there is that we're missing all of the signs leading up to that, right? All those little
Oh,
subtle signs and changes, and those are the things that we miss because kids look great until they don't. So it ties into that, like,
Yeah.
what is that pre phase versus, up, they are falling off of that cliff? Because that, I think that's
Yeah.
obvious, but how do you pick
I
that up before you get there, right?
well, you might have some information from dispatch to be
Yeah,
able to consider as far as that. So, the quality of your dispatch, and also it depends on the information you're receiving from the family. So,
yeah,
I'm sure you've been on scene a lot of times, and the information through dispatch and the questions for the family, and you get in scene and it's nothing like what you were prepared for. That's
yeah,
actually a really common thing that happened to me as a transport nurse. And,
yep,
when I would be able to have some information, we walk into the room and it was not what we expected as
right,
far as that's concerned. So you're
yep,
always going to have those challenges along the way. I think it's also very challenging because as EMS, we have a much shorter time with the patient in general,
yeah,
and so the need to size up what is going on with the kid very quickly, sick, not sick, is
yep,
is having those basic skills down. But it makes it a lot easier if you have seen, sick and not sick. Lot
yep,
easier, sick and not sick. And again, what you're going to be looking for developmentally is going to be different. I love the fact that you mentioned, kids are little adults, that mantra, that we continue to move forward. There's two schools of thought evolving with this, and I think probably Peter may be in favor of the approach that you had suggested, that
right,
it's not necessarily that they're so different from adults. There are, and you can learn the other stuff. It does help that you see kids who are who are sick, because there's certain things that physiologically happen.
yeah,
Um, I had the benefit of being in the PICU and the ICU, and it being on the floors as far as that's concerned. But I was part of the code team, at Stanford, and putting that together. And what we would find in our quality improvement is, even on the floors in the pediatric units, the nurses didn't necessarily pick up that the child was changing.
yeah,
And so, first of all, don't feel like it's all on you, because even people who are pediatric don't always catch those signs.
right,
But you can only catch the signs that are in front of you, and have a strategy for basically what to do. For kids, prioritizing how to approach them in terms of airway management is critical. Being able to, provide appropriate sectioning, monitoring the patient, and looking at that respiratory effort that is going on, that work of breathing,
yep,
paying attention to accessory muscles. Um, yeah, right now I'm working with a group with the Pediatric Disaster Centers of Excellence on the West Coast, that's called RAPM. The point that I was going to make is that the physicians are actually looking for video of kids who are progressing. And so I started looking on YouTube for
yeah,
sick kids, yeah, as far as that's concerned. And there's actually a fair number of really nice videos. And in fact, people have put together, on Instagram or on TikTok,
yep,
um, videos that actually explain, then, okay, this is what grunting is. This is what,
yeah,
tachypnea looks like. This is what altered state of, what a seizure looks like.
yep,
And picking out the types of seizure. So there are actually resources that even medics now can use to be able to look for real video of real kids who, people have put out there, and and maybe use as part of their training as far as that's concerned. We the boon has been in simulation in terms of
Yeah.
helping train the hard skills, the intubations, the IV. And it depends on the assessment, asking the right questions, having the mental mindset when you go into the scene in order to collect the information and then determine. Those are the cognitive skills
Mhm.
that really simulation and the psychomotor skills that
The
are
muscle memory
that
things.
the muscle memory. Yeah. And I keep on explaining to, my colleagues in the med health side. I mean, if you took a firefighter's approach to basically, um, you know, bringing in that muscle memory, I mean, they train all the time, and they train because they need all the time because they need to be super safe. They have to
Yep.
protect themselves, and they have to protect their partners. Well, it's the same dynamic, and it's also, we have to approach it with kids. Is there an opportunity that we can build in that mentality and that approach to pediatric readiness? And how do we do that? Because it's part of our culture in EMS. It's part of the fire culture as far as that's concerned. We should be able to make that translation and 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 get that hardwired in some way, shape, or form.
Yeah. So, like at the agency level, then what do you think that some of the high performing pediatric ready systems do differently than uh, you know, the traditional or standard system? Somebody who
Well
excels at pediatric readiness.
well, I came from a well-resourced system, and basically in a well-resourced system, and being the EMS agency, and being an EMS director who basically said, "Yes, we will plan for kids." Basically, all I did was help set the expectation. I had authority, to be able to set that expectation. So having leadership, being able to set that expectation, that doesn't mean they have to be
Yeah.
the peck, but to set
Right.
that expectation is so important because whoever is going to be operationalizing that, whether for quality improvement or simulation, education, or being the, pediatric lead to pull these things together, they have to have the support of leadership,
Yeah.
and they have to have the permission. It needs to be out there that not this is what we're all going to do. We're all gonna participate in this.
Right. Yeah, I so recently I got to present my lecture to Air Medical Physicians
Mm,
Association in Tampa, and so it was a room full of medical directors, and it was pretty incredible to see the interest and the amount of people that grabbed me afterwards and was like that really hit. The whole concept of and in my lecture is built in that like listen like you have to have not just the provider on the street, but you have to have leadership and you have to have the medical director buy in to create this
yeah,
culture of readiness and to support those systems, right? We do it already with STEMI activations and code activations, and
yeah.
we have all these things in place, but pediatrics often gets left out, and that's not okay. And
Well, and I have definitely in working in the past on the state level is that pediatrics is not valued in some systems, um, eh, eh, because they have, and frankly, it's because they have competing priorities.
mhm,
They don't have the bandwidth. But I absolutely agree with you, Christopher. Not have you have to have a medical director who
yeah,
is going to support you in this process, because if you have that, you have you have authority to make it
yes,
happen. You have
yeah,
medical you have medical authority to make that happen in your community.
yeah,
So I would really I the interest in the engagement of medical directors in EMS is growing, but there's still, imbalance across the US, and not all medical directors are, the same. Um,
Yeah.
in they're not.
Yep.
They're
Yep.
not, you know? Yeah, we don't have Peter and Tubby solely as
Right.
medical directors.
Right. Yep. And I live in Ohio, where it's a home state. So
Mhm.
essentially, every medical director can create their own protocols and do whatever they want, as long as it doesn't supersede the scope of practice from Ohio. But the protocols, so like jurisdictions that touch each other could have vastly different protocols
Yeah.
based on whoever their medical director is. So
Yeah.
that can certainly be challenging for sure.
Well, we have that in California. It's
Okay.
it's the same, it's a home rule,
Yep.
as far as that's concerned. Now they do consensus as far as that. But what was really interesting as an EMS director is that when we were building our systems of care for STEMI and stroke and also cardiac arrest, you know, there was already standards in place or defined by organizations like the American Heart Association and
Mhm.
those kinds of things about what that was going to look like. Until recently in the Pediatric Readiness Project, we haven't really had that before. And now
Yeah.
that these expectations, national expectations are evolving, we are in a much better position to kind of step forward and actually make that happen. But
Right.
that means, again, everybody has to be on the same page.
Yeah. And, I think kinda adding to that, and that'll kinda transition us to this next stage here, is when the gray book for trauma services added that they need to have a PEC, right? Like, was I think is huge and instrumental, and that kinda drives us to the transition here. So if pediatric readiness really improves survival, the next question becomes who's responsible for making sure it actually happens, right? And that kind of brings us to that PEC role and why it is one of the most powerful, most misunderstood tools that we have at the local
Mhm.
level. So, for listeners who may not be familiar with what a PEC or Pediatric Emergency Care Coordinator is, and what problem was that role really designed to solve?
Mhm. Yeah. Um, so what I would say is that you need to understand the role in the context of seeing pediatric readiness as a quality improvement program, just like STEMI and cardiac arrest and stroke and sepsis. Okay,
Yeah,
you have to if you approach it from that framework, you will always find that in those other programs, there were people who were leading those efforts, being that champion, and
yep,
and that is what the PEC is, and they are basically equipped now. We actually have, with more guidance, the checklist. The
yep,
checklist is an assessment. It's a self-assessment. It is a agency assessment. It all of that data comes up. It provides awareness of what of the assessments is across a state or a region or nationally. So it gives us a starting place. So we've had that benefit for the pediatric emergency departments. We have not had that benefit, and we're waiting. I'm waiting with bated breath for the pre-hospital, readiness data to come out and have
yeah,
that final paper. So I think that's coming out in the next few weeks. It may be out by the time this podcast goes live, and as
right,
far as that's concerned, so that's probably one of the reasons I can't speak to it. But we do know that one of the areas that is a focus area, just like it was for the hospitals, is getting that role of the Pediatric Emergency Care Coordinator established. And
Yeah.
so because EMS is so different all across the country, and there are many, many EMS communities that are resource constrained. There's also many ways that you can accomplish putting a PEC program together. And so it's okay to have a PEC that is not just agency based, but maybe over several agencies, as far as that's concerned. And that person isn't a person of authority. That person is a person of improvement and and
Yeah.
a facilitator, a communicator, a coach, maybe a mentor. Maybe that person doesn't even have that much pediatric experience, but is willing to learn it along the way. And you learn by doing. You
Yeah.
learn by working these pediatric readiness expectations. So it's like you do not necessarily have to be the world's expert in pediatrics. You do need to have relationships and with people who are more experienced in pediatrics than you
Yep.
are. And through that process, you are going to be a conduit for maybe for actually translating that knowledge into your agency and your community and your other, fellow EMS providers.
Yeah. So when I give my lecture, I always say that the PEC is really it's just someone who's passionate about pediatrics. They don't have to be a specialist. It could just be someone who has a little bit more interest about it than anyone else, and that they're the ones that keeps pediatrics from being an afterthought. Right. So when I go through the roles, like the duties or things that a PEC does, I always say like, listen, they don't need to do right. They don't need to provide the education. They don't need to write the protocols. They don't need to do the QA and QI. They just need to make sure those things are happening, right? And find the
Right.
people that can fit into those roles and do those, and that making sure that they're including pediatrics into those thoughts.
Yeah, and again, it's not that you have to make it up. There are subject matter experts groups who are developing the protocols that basically stretch from the field to the emergency department, that you're going to be able to leverage that education, that training.
Yeah.
We have so much training available. We have so much training available. The information is out there, and the
Right.
more you expose yourself to it, and then we have some various priorities that are being looked at for 2026 in the emergency department. Those things will, end up being prioritized as part of the pre-hospital assessment. And one of the other cool things that is happening, because I am on the pediatric pre-hospital steering committee for the assessment. Um, the cool thing that happened for the emergency departments is that they left the survey open, so that people could take the survey at at different times and
Yeah.
watch their improvement happen. So my understanding is that with the 2026 pre-hospital readiness assessment, what is going to happen is that there's going to be you're going to take the assessment, but they're going to end up leaving the resource open so that you can take it multiple times before the next um, period of time. Because I think, let's see, the first assessment was what, was it 2022? Um, uh, Christopher, do you remember?
Uh,
I
yeah, I'm
don't keep
trying to think of
numbers
what
in
year
my
it
head
was.
very
Yeah.
well,
Yeah, I'm trying to
but
think of what year it was.
it was
Mhm.
several years ago. But the thing is that as you put in interventions, you can take that information from your own data set and then help inform you about
Yeah.
retaking the assessment and show and hold out that progress. One of the things I would really like to see happening is a lot more transparency in terms of, within the agencies and in the states and that type of thing, because it would really help us over time. I know people are sometimes nervous about transparency with because they feel like they're being judged or something
Yeah.
like that. But in quality, when you're doing quality work, transparency really helps you understand because you can then bring more people to the table to get to the solutions that you need faster, is the way that
Yeah.
I look at it.
Yeah. So a couple things there. So that was one of my big frustrations is that I would direct people to go do this survey and it was locked out, right? They missed that time
Yeah.
frame. So like I think the ability to go in any time and complete that would be huge. And so one of the other things that I implemented prior to leaving the regional pediatric center that I worked for
Mhm.
was that we actually worked with agencies to try we tried to get everyone to fill out this pre-hospital survey. But what we actually implemented right before I left, I built this program where the our PEM fellows, so our ED attending or
Mhm.
fellows would come in and they had X amount of clinical hours that or I'm sorry, non-clinical hours, right? So office time. And a portion of that was dedicated to EMS. So what we did was I created this whole curriculum to where the PEM fellows would go and do they were already doing ride time when I started. So they
Mhm.
would go and do like 8 hours of ride time. But there was all these extra hours that they needed to fill and I was like, "Well, let's do this." I was like, "Let's turn our PEM or our fellows into PECs for the agencies that surround us." So what we did was we built a system where our fellows would come into the program with the expectation that they get assigned to a fire department that was close to the region, within the county of the regional pediatric center. They functioned as their PEC. The first thing they would do is do the pediatric readiness assessment survey, evaluate where they were at, set baseline, and then the fellows would go and be their PEC, and then they would start to, evaluate what equipment they had, what training they were receiving, and then they would review X amount of runs each quarter, and then they would provide
Mhm.
education based off of case review, off of those runs, off
Yeah.
of the QA/QI, and then start to build these relationships, and then, after a year, repeat that survey, and after 2 years, repeat that survey and see what that pediatric readiness impact looks like by embedding a pediatric fellow from the regional pediatric center in with their agency.
I love
And
that.
yeah, so that all got up and running right before I left this organization, and I have one physician that, he's a EMS medical director that still texts me. He'll send me pictures and he'll be like, "Oh, the fellows are out here teaching, like, things are great." Like, he's like, "This system is booming." It's very rewarding to know that that's still growing even after I left, and, but that was the plan was to do research on that and present that at a conference so that other people could start to
Right.
and now, as you mentioned earlier, so I sit on the state EMS for Children board here.
Mhm.
Even after leaving, the pediatric center, they were like, "Please stay on with us because this is my passion." So I still sit on that board, and now all the other pediatric hospitals in the state are looking into how they can implement that and start that, as a pediatric facility and start to do that
I
outreach out.
yeah, there's a lot of things that are happening that are really positive for pediatric readiness, but there's also some real world systemic challenges that are happening
Mhm.
to the access of care for pediatrics.
Yeah.
We we lost a lot of pediatric beds during COVID,
Mhm.
because that space needed to be used for adult patients and pediatric patients and pediatric nurses or no, I should say pediatric nurses were laid off during that time or they needed to take care of adult patients. Many of those people didn't come back.
Yeah.
And many of those positions didn't come back. Those beds didn't come back as
Yep.
far as that's concerned. Why I mention that is because we lost that capability, and that is having an um, un you know an unintended consequence on the EMS delivery system in terms of being able to take a really sick kid and get them to an appropriate level of care.
Yeah.
So uh, we know that 80 to 85 to maybe 90% of the kids that we take care of go to regular community hospitals. That's
Mhm.
why the focus on pediatric readiness for every community hospital. We know that with the trauma designation for all hospitals, that the expectation now that's written into those regulations for recognizing trauma centers, it now require that they participate in the pediatric readiness program. So that's a
Yeah.
big, big win. But at the
Yeah.
same time, we are seeing the pediatric bed capacity um, basically moving to highly urban areas and being kind of very concentrated, and
Mhm.
it's extending basically transport times.
Yeah.
So you're going to be and you're getting a lot more interfacility transports and the and that may be okay for, the onesies and twosies that we deal with, in EMS, but it doesn't work very well when you're talking about a mass casualty that is in
Yeah.
a particular place, and you have to transport kids all over basically the community and so we're talking about transport times now of potentially very critical kids of not just 10 minutes or 15
Yeah.
minutes or even a half hour. These are hours, and in some states you're talking about the only way that the kids are going to get there is through air medical, and and because there are no resources in the state, or all the beds are full in your state, which is
Mhm.
happening more and more. So we have all these systemic challenges in in terms of getting kids to the appropriate level of care that EMS is going to be caught in the middle. So this makes it even more important that we make this a priority at this point in time because
Yeah.
we're gonna be dealing with these kids en route, and the better we can do it, the we will be doing such an amazing service not only to our communities, but also we'll be taking care of ourselves. Because I want everybody who takes care of a kid to be able to, no matter what the outcome, to look at themselves in the mirror and be able to say, I did everything I could possibly do.
Yeah.
I did my
I
very best. I
yeah.
did my very best and own that, and
Yep.
even though it's always tragedy that when we lose a patient or it has a bad outcome, people need to come away with, intact.
Yeah.
I mean,
Yeah.
they need to come away intact.
Absolutely, and that's one of the big parts about my reducing the pucker factor lecture as well, is that it's not just about patient outcomes, but it's also about taking care of ourselves and our own When we know that our agency has our back and we have the resources and the right tools, and that's one of the things that I talk about often is that I work for an agency that I have the ability to function at a very high level. So I know, and I have the confidence and comfort level to deal with pediatric patients. So I know when I show up that I gave that patient every possible opportunity at a better outcome. Even if the outcome is undesirable, I know that I did everything in my power to make that situation just a little bit better. And that's how I'm able to walk away from those situations still feeling positive and not
Mhm.
run down. And I talk about that where reducing the puck factor in pediatric readiness, yes, it improves patient outcomes, but it also supports our provider mental health and longevity and all that well as well. So like that was kind of the joke is like, you know, I know that I rocked it, right? And
Mhm.
so then I'm able to walk away and I'm able to lay down at the even though the outcome was poor, I know that I functioned at a level that gave that child every opportunity a better
Every
outcome.
opportunity. Exactly,
So, yeah,
exactly.
and
It's so important to be able to walk away from those situations feeling like, you know, I did everything I could, yeah, with it.
yeah,
Because you want to be able to you wanna if you're leaving a kid on scene, yeah, as far as that's concerned, who, because of resuscitation or any
mhm,
those are very challenging situations to deal with as far as that's concerned. Having it's not just you. You have to have your whole team people and support system in
yep,
there, and knowing that it's a good idea, it's more than a good idea, it's essential that someone from your team is basically with the parent to explain what is happening in front
yes,
of them
yeah,
because these parents are on scene and they're watching everything you're doing.
yep,
And so we in the hospital, we basically try and have there's controversies about yeah, and under what circumstances to have a family in the room as far as that's concerned. But if they are in the room, you need someone assigned to them in
yeah,
order to explain what is happening in as calm a manner as possible.
yep,
And you're still even you're still going to be taking care of the family on scene before you end up taking care of yourself.
yeah, yep,
And this is
so
this is the challenge of EMS.
oh, absolutely, 100%. So, I would love for you to, be able to see my lecture because, like, a lot everything we're
Oh, I
talking
love
about
it, yeah.
is included in there. So, family-centered care is one of my passions and soapboxes, and I will talk about that for, forever. So one of the things that I talk about is that, we have to include the family in there, and sometimes assign I always say that they should be involved if they wanna be, but we have to assign somebody to the family that can communicate with them and explain to them what is happening, why we're doing these things, and doing all that, as long as it's safe for the providers and the
Yeah,
crew and all that stuff, right? Outside of that, but we have to include them into that. And it's just it's not a nicety anymore. It is evidence-based, it is supported, like, they need to be involved in that. And I say sometimes that having somebody assigned to that family is almost just as important as chest compressions or IV access in some of those
mhm,
situations because we know so families their child is not dead until CPR stops, right? So in their mindset. So as long as we are doing things like we need to communicate to them and explain to them what is happening and talk them through that process. And so one of the things I talk about recently, I had a case very recently. It still sits very heavily with me. Uh, I don't know, have you heard the story of I think his name is Jamie, where it's on the EMSC website where the crew handed mom the sock of the child that was struck by a bicycle?
Oh, no, I don't think I know that
Okay,
story.
so I'll send it to you, but
Yeah, I'd love to see
I've
it.
told this story. I've told this story. So basically, the crew the child was struck by a car, and EMS was dealing with mom on scene. And as they were starting to pull away, the EMS provider, one of the first responders, stopped them and handed mom the sock from the child that was on the
Mhm,
scene. And the mom says, that probably sounds like a very ridiculous thing to do. She's like, however, my son died 3 days later. This
mhm,
is now 6 years later, and I still have that sock and the memory of one person's kindness. And she goes on to say, she goes, the end of the story says, "This may be a very odd way to say it. Even though our child died that day, our experience overall was very positive." And I hit on that. I'm like, that is the impact. Can you imagine that somebody lost their child and they can look back and say, "You know what? Our experience was pretty positive," because that's the impact that EMS can have when they
mhm,
do that. And so going back to my story, I've told that story for years, and now just back in January, I had a case that was very similar, exact same age, almost exact same situation, and we showed up to take care of this patient, and we walk in the room and this EMS transported the patient at the ER. We flew to the ER to transport this patient. And we get in there and they're doing CPR, and EMS had already put in an airway. They got access. They were doing high quality CPR. They needle decompressed both sides of the chest. And we got in there and we did bilateral finger thoracostomies
mhm,
and ultrasounded just to make sure. And by this time, it was like 40 minutes, 45 minutes downtime.
mm,
And we started transitioning to, we were going to call it, but we were going to bring family in. And
yeah,
we arrived and all of that stuff was already done,
right,
so I knew family was coming back. So the only thing I could think of was start to clean up the room and clean up the patient. And I washed the patient's face because
yeah,
there was blood and stuff. And so I started cleaning up the patient's face, and it felt so minimal in that moment. And the
mhm,
mom walked in the room and got the information, and the very first thing that she did was lean down and kissed his clean forehead,
mhm, mhm,
and, uh, that was the most impactful thing that I could do.
yeah,
And then to be able then to go and debrief with that team, with that EMS crew afterwards, and you could tell they were like, "Did we do the right things? What did we do wrong?" And
mhm,
I was able to stand there and I was like, "Listen, like, as a critical care flight nurse, paramedic," I said, "everything that I had in my brain of what I was gonna do when I walked in that room, you had
mhm,
already done it. I didn't have anything left to do because you rocked it. You did
mhm,
everything phenomenally," and you could just see the weight. Their stances changed, their demeanors changed, and it was just like, right?
yeah,
And just to
a sigh of relief. Well,
yeah.
and the thing too, Christopher, I mean, what a great story and stuff, but it demonstrates is that our providers go right to, "I did something wrong," when
Uh-huh.
you don't have a good outcome, and there are things you just don't have control over,
Yep.
and it is not your fault.
Yeah.
And the fact that we even have EMS in critical care, to the extent that we do, the it there will be children and there will be adults who just, it's their time.
Yep.
It's their time,
Yep. And
you
I
know,
I
and
tell
and
Yeah, go ahead.
that's so important.
Yeah, I so I've told this story many times, but I try to get it out there as much as I possibly can, is that I joined the fire service. So actually my very first day of training at the fire department was September 11th, 2001.
Mhm.
And yes.
Oh my God.
So I was in I finished up EMT school, and that was my very first day of training. So I started way back when mental health and resiliency and all that stuff was not talked about. And one of the very first calls I responded to was a quadruple fatality accident, and they were all right about my age. And I really struggled with that call. And I remember one of the
Mm,
guys he told me two things that have stuck with me throughout this entire time is one is once you realize that you didn't cause it and that you're just there to make that situation just a little bit better. If you can go in and do anything to make that situation better, that is what you were there for. And the other part was talk about it. Never bury it
mhm.
down in and always just talk about it. The more you talk about it, the more comfortable you're going to be. And those are two things that have, and again, this was before mental health was accepted in the fire service. And those two things have stuck with me throughout my entire career. And those are the things that have helped me grow tremendously and stay to the point that still be in this
Yeah.
career this many years later.
Well, very smart mentor, but, and to have people around you to give you that guidance to help carry you through to, what you're doing now is
Right.
like, yeah, it's amazing, the impact that conversations and having
Yeah.
the right people around you can be, and we need to be extraordinarily, kind
Yeah.
to ourselves and also to the EMS community as far as that's concerned. There are so much stuff that you guys just don't have any control over whatsoever, and
Yeah.
yet, there's all these unrealistic, metrics and,
Yeah.
that you guys have to struggle with, day in, day out in terms of proving your worth and
Yeah.
and
And
stuff. It's challenging. That's probably I mean, gosh, I just looked up, for another talk, what the average, length of stay, of, in the field of EMS is. And, so some of the stuff that came out of that is, after EMT, school, a lot of people leave after 3 years, or
yeah.
and move on and do something else. And for paramedics, it's 5 years. It's that most people we're old timers,
Right.
you
Yep.
know? And
Yeah.
I didn't grow up in EMS, but, transferred, but I am so grateful for what I learned during my time in supporting, my EMS community. I am so
Yeah.
grateful for that experience.
Yeah, absolutely. And so the what's interesting is the agency that I started out that gave me that information was a part-time slash volunteer rural agency. And that
Wow.
segues us into that next section, right? Of not every agency has an educator, a quality department, or that extra bandwidth, and
Right.
especially in that rural and volunteer systems. So, from your perspective, then, what are those biggest barriers that these agencies face
Yeah.
in being pediatric ready?
Well, I mean, all the ones that you just listed as far as that's concerned, but I will
Yeah,
tell you, I think the dynamic then has to shift back to the hospital community, like the example that you gave with the PEMS, you know, and I think help, in that way, help can be on the way. I think getting the rural communities just connected to the EMS for Children's program just connected to the program, and knowing what's going on as far as that. That's a relatively easy lift to be able to do. Doesn't cost a lot. It doesn't cost any money. Just so that people know that there is an EMS for Children's program in the state
yeah,
and that they can reach out and have a conversation and present their situation to the EMS for Children's program, because the people who are leading that effort have a better understanding of what is happening in the state, the region, and in the community, and they may be able to connect the resources to that rural agency or to that region or that locale as far as that's concerned. I think your example of having the PEMs, adopt the fire agencies, we need people who are leading that effort, and the PECs that are leading the effort in the hospitals, in the well-resourced areas, be
Mhm.
able to adopt, I mean, literally adopt some of these other communities. It's about connection. I think
Yeah.
what's gonna solve it is not to have, bang, agencies over the head that simply don't have the resources to do it. I think it's
Right.
the solutions will be found in connections, to connect them with the EMSC program, connect them with the leadership in the community, and to leverage the information that is already out there, so it does not need to be a hard lift. It can be a
Yeah.
helped lift.
Yeah. Now, you often hear that won't work for us, right? Agencies are like, that's just not how we work. So, what are
Yeah.
some examples where rural or volunteer agencies have made readiness work despite those constraints? Where there's a rural or volunteer agency that's
Okay.
that's doing it.
I don't have a great answer for that.
Okay.
Um, what I do know is that in the state of Florida, for instance, there are it- they they decided to put together their state recognition program, um, uh, and start with pre-hospital first.
Oh,
And so they did some very interesting things. And so part of this, I think, is looking at how the rural communities kind of came together. And then again, they did it as a group, as far as that, and to achieve that recognition. And so, what I'm observing from hearing about those circumstances, because I don't live day in and day out with the community, is
yeah.
that in as the recognition programs are rolling out, there is a, there's a little bit of status that goes with that makes it desirable and
Yeah.
more people interested in doing this than not having recognition. It's the same thing about, being recognized as a STEMI center or a stroke center, or, I
Mhm.
mean, that's that it gives a little bit of status with that, okay? S-
Credibility. Yeah.
And credibility. Yes,
Yeah.
credibility. But behind the scenes, there's this collaboration that's happening, and it's going to look different in every community and in the rural community, but there has to be a way that we can create relationships between well-resourced communities and rural communities that are volunteer or not resource, and make that work for people.
Yeah.
And I think the hospitals and the healthcare coalitions could be a conduit for that.
Yeah,
Um,
I believe strongly in that. I think the hospitals are the ones that need to, and that was really the goal behind the project that I started as the regional
mhm,
pediatric center, is like I felt it was our responsibility to go out into the community and support those agencies that may not have the resources to set up a PEC or somebody that and assign them, and they were all like, yes, absolutely,
mhm,
and they're
yep,
fully enjoying the benefits of it, of getting the education, where they have multiple doctors coming out and providing hands-on skills training, everything just kind of fell into place because at that moment there was a respiratory therapist that was a paramedic who's also married to a firefighter paramedic that moved into like the simulation coordinator role. So then they were all able to partner and do like it just everything just worked and the feedback has been phenomenal. So I agree. I think it, and I say that as when I go through the tasks of the PEC, one of those is collaborating with regional pediatric centers and local hospitals and
Yes.
other agencies and sharing those resources and education and support so that everyone is on board with that.
Yeah, these are solvable problems. Okay,
Yeah.
and sometimes people say no, or we can't do that because they don't see it as solvable. So,
Yeah.
um, it can happen. It's just maybe they can't carry the water to make it happen. So, you know, it, it's like, well, let's keep the conversation going.
Yeah. I
And
I
so
I can
and so
carry you some water. Yeah.
let's keep the conversation going and help me understand, from your perspective, you know, if you could snap your fingers, what would you need
Yeah.
in order to make this work? And then out of those 5 things, we can, let's just start with this little thing. Let's
Yeah.
start on the ground floor.
Yeah. Yeah. And
You know,
it right. And the
because it's
neighboring
doable.
agency. Yeah, and the neighboring agency may say, "Oh, you know what? I can bring you water, but I can't do anything with it once it gets to you.
Yeah.
I have the ability to do this part, and then once you have it, you need to take the rest of it." So,
Well, and we're seeing more collaborations between community hospitals and their EMS that can be, in rural communities. And definitely that has happened in other places. And when that does, it really is a workable solution. Now, they
yeah,
may not be able to do it all the time, but the thing is that if you get it started, you want to have some regular cadence so it's sustainable. You want to make it
yeah,
realistic. And if you have to tug on your state EMS um, um, for children's coordinators or program to help generate ideas or to put you in contact with other resources and people to be able to say, I have this situation, I'm here, but this is more of what I need. They could, create opportunities. We have options now in terms of virtual education. I mean, people are working on gaming programs,
yeah,
but what is missing with that education is the coordination piece. And
yeah,
so, how can we do it? Maybe you get your local EMT schools or your paramedic schools into the mix, and maybe they end up strengthening their pediatric program, as
yeah,
part of that. Well, I mean, I'm in favor of a whole conversation about all of this
yeah.
stuff.
Yeah, no, so that actually brings up a good thing that I haven't really thought of is that this is something that, the, paramedic program in my region, like, that's something that's being done locally, but I've not presented that at the EMS for Children board, and, the EMS for Children board meets at the same time as the education board. So,
Mhm.
why couldn't we, as the EMS for Children board, create a white paper or suggestion or hey and reach out to the education board and say why don't we look at the curriculum and try to this program's already doing this and that's one of
Mhm.
the things I find often when I start talking about pediatric readiness is that nobody has to invent the wheel. Like, there are so
Oh,
many
no.
resources out there that the implementation is literally copy and paste, and pull the resources that are already built for them out there, taking a lot of that workload off of them.
Yeah,
So,
exactly. I mean, please, I call it reinventing education. I call that rinse and repeat. It's a waste of time. Okay.
yeah,
You want to leverage the information that is out there. Yes, you may need to adapt some of it, but typically you can almost find a perfect, circle to go through that, that, uh, to find that solution. You have that arrow hit its target, so to speak,
Yeah.
most of the time. And with the robust resources that are being created and being disseminated with the EMS for the pre-hospital readiness program, as well as the regular readiness program for the emergency departments, you just have to choose what works for you.
Right.
You don't have to start from scratch. And then I always like to, encourage what I call small bites in terms of education. I would do that as an educator when I was at Stanford. I spent 13 years as their educator. And I would, it would be like, okay, I'd go up to the floor and grab each, a nurse for less than 3 minutes and say, okay, I want you to test the defibrillator. I
Right.
want you to practice turning on the oxygen on the
Yep.
crash cart, you know.
Yeah.
I'm going to bring up a little mannequin and we're going to bag the baby for, and practice those skills on the ward, because the nurses on the ward don't get to do that as much
Yeah.
as you guys in EMS get to do it in
Yeah.
practice. And they have to have those skills too. So take it in little small bites, people coming on, shift have a little station off to the side, and then, with a board or a little video or something like that, now practice as far as
Yep.
that's concerned. If you have trouble, give me a call.
Yeah, I speak to that a lot too in my lecture, and one of the things I mention
Mhm.
about is just like the micro learning, right? Those are the things, and I'm like, if you have a TikTok brain like I have now, where it's just that scrolling, and like if you don't have me in 2 to 3 seconds, like it's on to the next thing, and
Yeah.
that's how a lot of us, our brains are just programmed now, and that's how we learn. So it's those small chunks, easily digestible, and that's what my whole platform has been about, is taking these complex subjects and breaking them down into smaller, easily digestible chunks and tricks of the
Yeah.
trade, and making them just a little bit more easier to digest.
Well, yeah, and EMS has a rich tradition of basically, just in time learning,
Mhm.
to be able to learn from each other, to improve from, by sharing with each other. It, 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 it- and it is in the doing. It is in the actual psychomotor and the doing that we
Mhm.
hardwire those skills, we hardwire those approach, and just like you're learning when you learned intubation, it's the same methodologies. You're just applying it to a different population.
Yep.
That's you know that's what you're doing.
Yeah, absolutely. So as we transition into the last part here, right? So we've talked about survival, we've talked about PECs, and
Hmm.
really the real world challenges agencies face. But I think the next question then is, how do we measure progress? And that kind of brings us up to that upcoming 2026 pre-hospital pediatric readiness assessment. So for
Yeah.
listeners who may not be familiar with this, what is the pre-hospital pediatric readiness assessment, and what is the purpose of it?
Well, the pre-hospital pediatric readiness assessment is a checklist. And basically, people go through the checklist. It has various sections: education and competency for providers. It asks, do you have a process for evaluating pediatric specific competencies like, airway management, that kind of thing. It's a checklist that includes, do you have the equipment and supplies you need for kids? And
Yeah.
then, do you have processes in place to ensure pediatric patient medication safety as far as that? Because medication safety is huge in
Yep.
kids, and we need more help with it and
Yeah.
than in other places. And patient family care, you've already we've had a conversation about that already. Policies and procedures. Now, that's probably something, we're a protocol. EMS is protocol driven and stuff. So
Yep.
frankly, that's low hanging fruit. That
Yeah.
that is one of the that's an easy thing to be able to evaluate and improve right away if you don't have those policies. And then are you looking at a quality improvement? And that means, being able to do case reviews, but also being able to track things over time in the pediatric population. That
Yep.
could be really helpful. And putting it through the plan, do, check, act, system. And then finally, interacting with those systems of care. What we are doing with pediatric readiness by focusing on both hospitals and pre-hospitals is we are attempting to build a system of care for children associated with emergency, just like the system of care for STEMI and
Yeah.
stroke and cardiac arrest, all of those things. And we know we have a track record in EMS that EMS is the mission critical linchpin that makes it all work.
Yep.
I really believe that and stuff.
Yeah.
So, you are the linchpin as far as that's concerned. This is a great program and to be involved in. It will increase people's confidence and capability, and it's not as hard as you can. And there are plenty of people. There is a whole national community of people. You know, Christopher, you're one of those. Yeah, as far as that's concerned, in terms of boots on the ground, making that translation work for your, community, and to show people how it can be done. So,
Yeah.
get in there. You kind of sometimes you just have to jump in.
Yep, absolutely. Now, some agencies may worry about being judged or penalized. I think we talked about that a little bit, right? So, how should leaders kind of reframe this assessment so it becomes a tool for improvement rather than, a source of anxiety or something of that sort?
Yeah, I wish everyone was wired with the sense of we're on a journey for improvement here. There is, people will make mistakes, and we expect that. We
Yeah,
expect that there will be gaps. And, the point is that you identified the gap. And now you have methods of moving the needle forward.
yeah,
Um, but you will always run into people who judge. And sometimes those people come from outside of the community.
uh-huh,
So, you know, but what you don't want to be in as this becomes more of a standard of care in terms of engaging, you don't want to have a bad outcome happen anyways, but then
yeah,
have that bad outcome shine a light on that you didn't have or you didn't take advantage of, you know, things that would have prevented that. This
yeah,
is, in disaster, we call this disaster, we're calling this, um, risk mitigation. This is These tools reduce your risk on a professional level, on an organizational level, on a state and region level.
mhm,
This is risk mitigation. This is risk reduction. Everybody can get on board, and even the people who are running your agencies and stuff. This brings value. When you're able to reduce risk, it brings value to your organization. It brings value to your community. We have
absolutely.
this program because we reduce the risk to the children in this community. That's a
Yeah,
really powerful message.
truly is. Absolutely. So, if the 2026 assessment succeeds, what do you
Mhm.
hope it changes about pediatric care 5 or 10 years from now?
Well, if everybody gets on board, yeah, as far as that, we will be building a much more confident and capable EMS community. And
Yep,
I'm hoping that our EMS pediatric professionals, and stakeholders will grow. And
yeah,
then when that happens, I'm more confident that if we can make that work in the everyday, we will have increased the capability for dealing with children in disasters because readiness and disaster readiness are two sides of the same coin.
yeah,
The
absolutely.
disaster readiness is your foundation, and I'm sorry, your everyday readiness is your foundation, and your disaster
Yep,
readiness is what you have to scale.
yeah,
When w w you know, and how you scale it. You can't do
absolutely.
that in a vacuum. You have to know what you have in your hip pocket for taking care
Yep.
of kids.
Yep. I say that all the time is no pediatric call happens in a vacuum.
Mhm.
So as we wrap this up, I kind of want to sit with something that's come up again and again in this conversation, and it's that
Yeah.
pediatric readiness isn't about perfection. It's
Mm-mm.
not about having every piece of equipment, every policy written, or even every scenario rehearsed. It's about intention and ownership and that willingness to admit where systems fall short before a child pays the price for that. And, what you have shown us today isn't that survival isn't accidental, it's built, it's planned, it's reinforced at that local
Mhm.
level by the people who really care enough to own the work. And whether that's through readiness assessments, PEC roles, or small, steady improvements in that rural and volunteer agencies doing the best they can with what they have and what they have
Mhm.
available to them. So the thing is, kids don't get to choose where emergencies happen.
Yeah.
They don't get to choose the resources available, the call volume of the agency, or whether a system decided pediatric care was a priority this year. They just show up and they depend on us to be ready. And so, if you're a leader listening to this is your reminder that pediatric readiness is a leadership responsibility. If you're a frontline provider, this is your reminder that asking for better systems isn't complaining, it's advocacy, it's advocating for your patients. And if today's conversation made you uncomfortable at times, that's okay. Growth usually starts there. That's where we start to grow. So, Patricia, thank you so much for your work that you've done, the systems you've challenged, and the lives that you've impacted, and many of whom will never know your name, but are here because you refuse to let children be an afterthought. And this has been reducing the pucker factor. Stay curious, stay humble, and above all, stay ready. And so, Patricia, this is where I like to give my guests the opportunity to share any parting words or final statements before we sign off here. And please let our listeners know what platforms they can find you on and any
Yeah.
final parting words.
Well, again, that two sides of coin, we're all invested with this. It is, you by stepping into Pizza Readiness, you are stepping into a large community of people who are passionate about this,
Uh,
who are willing to help, and can help connect you to educational resources. At the National Pediatric Disaster Coalition, that is
yeah,
part of our mission in terms of connecting novice to expert. And we have a website that really is focused on pediatrics, including pre-hospital care. It is very much whole community. We do have a listserv, but you can find us on LinkedIn. You can find us on Twitter. You can find, or I should say X now,
oh, yeah.
Instagram. Instagram, Facebook, and Blue Sky. And you can reach us and contact us through our website. So we're all in this together. And,
Yeah,
we need everyone being able to lock arms and move this forward. So hope, don't be intimidated because we all had to start someplace. And it's
absolutely.
so and getting confidence takes time.
Yep. Absolutely, and I always say, confidence and improving that comfortability reduces that pucker factor and makes that go away, so
Mhm.
absolutely. Thank you so much for joining and taking the time to chat with me. I absolutely love this, so
Well, Christopher, thank you so much. It's been an absolute pleasure, and I want to commend you on your efforts to make this happen. Um, and your podcast for the work that you're doing here. It's
thank
amazing.
thank you so much. I appreciate that.
Yeah. The call goes out and the crew's on the move. Lights up, crew locked in, yeah, we know what to do. Their hearts beating fast in the back of the rig. But we don't panic, nah, we're dialed in big. Scenes chaotic, kids sick, but we're right on track. We breathe deep, lean in, bring the calm right back. We're reducing the pucker factor, turning fear into confidence. From the med unit to the helicopter, bring the calm when the chaos won't stop, yeah. We're the Bickery content crew, showing what the pros can do. Turn the fear into calm under pressure. Pucker factor, gone forever. Pucker factor, gone forever. Yeah. Got skills, got data, got a plan that hits. Got the airway game strong and the trauma kids. Yeah, from scene to scene, we're raising the bar. EMS super nerds, yeah, that's who we are. Hey, for the medics in the front line, let's go. For the flight teams on the lifeline, let's go. For the ones who are running faster, we're reducing the pucker factor. We're reducing the pucker factor, turning fear into confidence. From the med unit to the helicopter, bring the calm when the chaos won't stop, yeah! We're the Blinkery content crew, leading what the pros now do. Turning fear into calm under pressure, pucker factor, gone forever. Pucker factor, gone forever. Gone forever.